Hello and welcome. I am Dr. Amber Cann, and we will be reviewing the pharmacotherapy of schizophrenia spectrum disorders. Let's jump right in. Several organizations publish clinical guidelines for schizophrenia. I've listed 3 here, but there are others, and your institution may prefer one over the other. Schizophrenia affects about 0.25 to 0.75% of the general population, so less than 1%, but it is in the top 15 leading causes of disability globally. It's characterized by persistent disruptions in thought processes, decreased responsiveness, impaired social and occupational functioning, and oftentimes hallucinations that are both auditory or visual. We categorize the symptoms of schizophrenia into 2 broad categories: the positive symptoms and negative symptoms. Positive symptoms can be thought of as the presence of problematic behaviors, where negative symptoms are the absence of healthy behaviors. Positive behaviors can be things like hallucinations, delusions, and disorganized thought. Negative symptoms include things like anhedonia, a flat effect or showing no emotion on the face, reduced social interactions, and generally less motivation, less initiative, and less focus on tasks. When we begin treatment for schizophrenia, we focus on these goals of therapy. First, we want to choose a medication that is efficacious but also safe, so eliminating or reducing symptoms of acute psychosis and reducing an immediate threat to self or others in the patient. We also want to minimize the toxicity of the medication that we select and use the lowest dose possible. It's important to improve adherence in patients with schizophrenia, and we can do that by selecting a medication that minimizes adverse effects. We want to stabilize the patient and reduce both positive and negative symptoms. And finally, we want to maintain the patient once they are stabilized, so reducing the risk of remission of symptoms, returning them to the baseline that they're expecting, and preventing a relapse. Similar to depression, we have some non-pharmacologic interventions available to us, and they are the RTMS, repetitive transcranial magnetic stimulation, electroconvulsive therapy, or ECT, and of course, any treatment strategy for schizophrenia should include psychotherapy or cognitive behavioral therapy. Antipsychotics work on a number of neurotransmitters and compounds in the body. They differ by the affinity that they have or the action that they have on these compounds. We'll focus on their action on the histamine receptors, dopamine receptors, acetylcholine receptors, and adrenergic receptors. First-generation antipsychotic agents are often referred to as typical antipsychotics, and I've listed them here. On the whole, these medications are very old, but there are newer versions and newer dosage forms that we can use that have better tolerability. Second-generation antipsychotics are often referred to as atypical agents. They also have action on histamine, dopamine, acetylcholine, and adrenergic receptors. They differ in the affinity they have for dopamine receptors. Indeed, some of them are partial dopamine 2 receptor agonists. There are quite a few more second-generation agents than first-generation agents, and there's been quite a lot of work and research that's gone into novel dosage forms in this category as well. I want to call out clozapine. It's an often used atypical antipsychotic agent, but it does have a number of boxed warnings. They can fit into 3 broad categories: neurologic warnings, cardiac warnings, and hematologic warnings. For clozapine, the neurologic boxed warnings, we have found that seizures are an effect, and they do tend to be dose dependent. Clozapine doses over 600 milligrams a day might be required to treat schizophrenia symptoms, but if they are, we do push that dose above 600 milligrams per day, we do need to put the patient on an anti-seizure medication. For the cardiac warnings, they are numerous. It could range from orthostasis, syncope, cardiac arrest, and bradycardia. So we wouldn't want to co-administer them with something that affects cardiac conductivity, and we don't want to give them, or we don't want to get clozapine to a patient who has an underlying cardiac abnormality. The hematologic boxed warning is the most commonly thought of with clozapine because there are specific recommendations and requirements for monitoring the patient for this effect. So the rare but serious side effect that clozapine can cause is agranulocytosis. So we must strictly monitor and alter the dose based on the results of CBC monitoring. Also, patients have to enroll in a REMS program, and that is to ensure that the provider and the pharmacy and the patient are in communication, and the patient's being monitored for agranulocytosis. This is the website that prescribers and pharmacies must register on for dispensing and prescribing clozapine. So the prescriber must enroll in this program in order to write prescriptions for it, and the pharmacy dispensing it must also enroll. And you can see there are a number of requirements for both healthcare entities in this system. I mentioned that we have to monitor the patient's CBC and specifically their ANC levels. So here is a rundown of the recommendations based on ANC. If the ANC is above 1500, then we can initiate treatment. So before we even start treatment, we have to get a baseline. We have to monitor that every week for the first 6 months. And then after 6 months, we can go to every 2 weeks if the ANC is remaining stable. After 12 months, we can push that out to every 4-week CBCs. If the ANC drops below 1500, so between 1500 and 1000, then we can continue treatment, but we need to up our monitoring. So we even need to do it 3 times a week until the ANC goes above 1500. If the ANC is dropping again below 1000 but above 500, at that point we need a hematology consult and we have to interrupt treatment. We have to hold the clozapine until we can figure out what's going on. So then we would daily monitor a CBC and the ANC until it goes above 1000. Then if the ANC happens to go below 500, we have to recheck it to make sure to confirm that is the correct result. We definitely need a hematology consult. We have to interrupt treatment, and we probably need to consider switching from clozapine to something else. There are a small number of people in the population that have a inherited condition where they have low ANC but no poor outcomes as a result. There are recommendations for a very small set of people that they can have clozapine treatment. Their ANC levels would just be different in the monitoring and the dosing recommendations. Adherence to medication regimens and doctor's appointments, lab monitoring has consistently been problematic in patients with schizophrenia spectrum disorders. And as a result, of late, new technology in dosage forms has really improved monitoring and dosing for these patients. One example is aripiprazole, and the brand name of the dosage form in particular I'm thinking of is Abilify Mysite. It is a form of aripiprazole that has an ingestible event marker in the capsule itself. The patient wears a patch on their abdomen, and when they swallow the pill, then the sensor on their abdomen marks the time and the time that the medication was taken. So it can alert a prescriber or a caregiver if the dose is missed, and they can keep track of when the dose is administered. There's an app, of course, for monitoring that the patient can use also for monitoring their own doses. We do have a number of injectable antipsychotic medications. Early on, we had injectable depot forms that were in the form of Haldol or haloperidol and fluphenazine. Those were IM injections either every 2 weeks or every 4 weeks. Newer technology and development of drugs has pushed that frequency out, and so now we even have IM injections that can last 2 months, even up to 3 months in some cases. The benefit of these long-acting depot injections of antipsychotics is that we eliminate the patient's need to take a medication every day. We improve, of course, compliance. But the downside is that we have drug on board for quite a long time, and if the patient does have poor outcomes or needs to be on another medication that could possibly interact, there's no way to remove that drug from the system. When we needed to administer a quick dose of an antipsychotic for an acute episode, we generally relied on injectable medications. And of course, when a patient is in distress, having a psychotic break, then getting an injectable medication in is problematic for caregivers. We now have an inhaled dosage form of loxapine, and it is approved for acute treatment of agitation in schizophrenia and also in bipolar adults. Like any medication that is administered into the lungs, we do have to be aware that there's a possibility of it causing a bronchospasm. So the box warning on loxapine does mention this, that there's a potential to lead to respiratory distress and respiratory arrest in very rare cases. The whole class of antipsychotic medications have a boxed warning applied. That warning is about use in elderly patients with dementia-related psychosis. Antipsychotics as a class are in the Beers criteria. They should be avoided, if at all possible, in elderly patients because of this risk of increased sudden death. Their action on so many different receptors also make them more likely to cause various side effects and have lots of drug interactions. For most of the antipsychotics, these are the contraindications for using them. They're not absolute contraindications, but it just means that if a patient has one of these disorders, then it could interfere with the antipsychotic medication, or it could cause a lot more poor outcomes. So those include, the contraindications include seizure disorders, movement disorders, blood dyscrasias, inability to adjust to extreme heat, any kind of cardiovascular disease, history of neuroleptic malignant syndrome, which we will cover in just a moment, and any kind of difficulty swallowing, as well as endocrine disorders like hyperprolactinemia. A few of the antipsychotics also have an increased risk of suicidal ideation. Those include the ones that I've listed here. The side effects of antipsychotic medications are particularly troublesome. They fit into this broad category of extrapyramidal adverse effects. They fit into further subcategories listed here: pseudo-Parkinsonism, acute dystonia, akathisia, and tardive dyskinesia. We'll talk about each one of those individually. You may notice within the first 1 to 3 days a spastic muscle contraction, usually in the head and neck. This is what we refer to as acute dystonia. Male patients are more at risk, young patients more at risk, and we see it in high doses and higher potency agents. We can manage it with an anticholinergic agent like diphenhydramine or benztropine administered IM. It's something to warn the patient about, and certainly something to watch for in the first days of monitoring. Because we are affecting dopamine receptors, it should be no surprise that we could push the patient into symptoms that look like Parkinson's disease. Symptoms like gait disturbances, some cogwheel rigidity, and bradykinesia. It turns out female patients, and especially elderly female patients, are more at risk for this. So it's something to watch out for. It could be confused with Parkinson's disease in these types of patients. It's also a dose-related response, so higher doses, of course, are more likely to cause it. We can also manage this with an anticholinergic agent administered IM. Patients also may complain in the first 3 months of antipsychotic therapy about restlessness, jitteriness, fidgeting, pacing, sometimes just a subjective feeling of restlessness. Again, high doses of antipsychotic medications are more likely to cause this, and if we titrate up too fast, we may see it. Certainly, if the patient is on a stimulant as well, you could confuse the restlessness and jitteriness of a stimulant with this type of feeling. We manage this with a beta blocker like propranolol or a benzo, less preferable, but also an option. Tardive dyskinesia is probably the most problematic of the antipsychotic medications. Symptoms would be something like a repetitive involuntary movement, usually again involving the face and the head. The problem with this type of side effect is that it may be irreversible. We can stop giving the medication if the patient experiences these medications, but in some cases, the patient still exhibits this adverse effect even after the agent is discontinued. People who experience extrapyramidal symptoms early in antipsychotic treatment are more likely to experience tardive dyskinesia. We can manage it with certain medications, but in general, we need to be very aware of it, slowly titrating, using the lowest possible dose, using second generation or atypical agents when possible, and then informing the patient and caregivers about the first symptoms so that we can manage it as soon as possible. Another serious side effect that is very rare but very life-threatening in patients who experience it is neuroleptic malignant syndrome. It occurs in less than 1% of patients on antipsychotics, but really there's no way to treat it other than with supportive care. We discontinue the causative agent. Signs that a patient may be experiencing in MS are high fever, high heart rate, elevated respiration rate, a lead pipe rigidity, and mental status changes. If we run labs, we may see an elevated CPK. This may help you remember the symptoms and signs of neuroleptic malignant syndrome. The patient can experience symptoms within 2 to 10 days of starting an antipsychotic medication. Heart rate, temperature, respirations all increased. Blood pressure may go up or down. You have to differentiate it between serotonin syndrome and symptoms of an anticholinergic. So rule out those things as well. But here's a mnemonic that you could use to remember what the symptoms are of NMS. And that spells out falter, fever, arms, leukocytosis, tremors, elevated CPK, and rigidity. Yet another adverse effect of antipsychotics is prolongation of the QT interval on EKG. We use antipsychotics with caution, especially in patients with existing cardiac arrhythmias. We know a lot of medications cause QT prolongation as well, and so managing drug-drug interactions is key with antipsychotics. We should always get a baseline EKG when we are starting an antipsychotic medication on a patient. The least likely to cause this is aripiprazole, and the most likely agents to cause QT prolongation are ziprasidone and thioridazine. One adverse event that patients often notice with long-term treatment of antipsychotics is disruption of normal endocrine processes. That could be hyperprolactinemia, galactorrhea, and gynecomastia in men, ceasing of the menstrual cycle in women, and sexual dysfunction in both men and women. It's more typical with first-generation agents, but patients really do seem to key into this endocrine disruption because it can alter their normal function. It may be something that's very disconcerting when they don't expect it. And with endocrine disruptions, we get a lot of metabolic abnormalities as well. So central obesity, gaining weight around the middle, hypertension, high triglycerides, low HDL, and insulin resistance. Again, more common in first-generation agents, but something to warn the patient about and to include remedies in their total care plan. Thank you for joining me for this review of medications we use to treat schizophrenia spectrum disorders.